lectures. The first lecture will cover pericarditis, pathology, and cardiac tamponade. And the second lecture will cover the constrictive pericarditis and constriction physiology. And I'm very thrilled to have you here today, to have you here today for the pericardial master class. And before we dive in, there's an old thing in medicine that says the eyes do not see what the mind doesn't know. And hopefully we'll make you today fully equipped to understand and see the subtle and not so subtle phases of pericardial diseases. These are my objectives today. And most of my talk will be based on the recent ESC 2025 guidelines on myocarditis and pericarditis. It's a very interesting document, and there are so many updates in it. It's also based on the International Multimodality Imaging Position Statement that has been released in 2024 in the Journal of American College of Cardiology. And starting from the very basic anatomy, structure, and function of the pericardium, the pericardium is a fibroelastic sac enclosing the heart. As we all know from our medical school, it's two layers. There is the fibrous pericardium, which is an outer inelastic in continuity with the pleura. And there's the serous pericardium. It's the inner side. It has two layers, the serous pericardium. We have the parietal layer that lines the fibrous pericardium, and we have the visceral layer, which covers the heart and the proximal great vessels. In between the serous pericardium, we have the pericardial cavity. It's a potential space with around 15 to 50 mL of serous fluid. And the reflection of the pericardium form the transverse and oblique sinuses of the pericardium. The functions of the pericardium, it anchors, that has a mechanical function. It anchors the heart within the mediastinum. It limits acute heart dilatation. It enhances ventricular interdependence. It reduces friction during cardiac motion, acting as a lubricant.
I'm very sorry, Dr. Dalia, to interrupt you, but still we are in the first slides.
Okay, sorry. No problem. Yes, apologies for that.
No
Yes,
problem.
yeah. It anchors the heart within the mediastinum. It limits acute heart dilatation, enhances ventricular interdependence, reduces friction during cardiac motion, and it also acts as a barrier to infection and inflammation. And the mesothelial cells of the pericardium also secrete mediators like prostaglandin with vasomotor function. Speaking about the pericardial sinus and the recesses, it's quite important to know the normal anatomy of the pericardium, so we would not miss it with pathology, especially when we see the pericardium and assess it in different cardiac imaging modalities. So, as I said earlier, the pericardium usually reflects around the great vessels, and it forms two big sinuses. Can you see my pointer?
Yes.
So, great. So in between, like there's the transverse sinus. The transverse sinus is usually a tunnel. It's only a tunnel, and it's caused by the reflection of the pericardium on the heart and great vessels. And anteriorly, it's what do you call it? Anteriorly, it's between the aorta and the pulmonary artery anteriorly, and the SVC posteriorly. So this is the transverse sinus, and usually it's an important landmark, anatomical landmark, especially for cardiac surgeon, where they usually can clamp the aorta. They usually put their hands, and they can usually, what do you call it? They can clamp the aorta and access it here. Then we have the oblique sinus. The oblique sinus is a blind fold, a blind reflection of the pericardium. We call it cul-de-sac, where the pericardium reflects between the left atrium anteriorly and the pulmonary veins and the IVC. And each sinus has recesses attached to it. And these are kind of small extensions from the sinuses. This transverse sinus has the superior pericardial recess, which is around the aorta, here, and here. and the oblique sinus, which is here. And it's usually the oblique sinus, if you put your fingers, like, when in cadaver or even in cardiac surgery, you usually it's a space here, but it's usually a blind space. And it has small recesses attached to it, which is usually around the pulmonary veins. There's the left pulmonic recess here, and also there are pulmonary venous recesses around the pulmonary vein here. This is also how you can see them. This is in ex vivo. So this is the transverse sinus, and this is the oblique sinus here. And this is how it appears in cardiac CT. So this is one of the recesses. So they look like a fluid-filled spaces around great vessels, and we shouldn't mistake them for pathologists. The pericardial thickness, the normal true pericardial thickness is 0.4 to 1 millimeter. In imaging, usually it appears a little bit thick. So in CT and MRI, it's around 1 to 2 millimeter. We usually call the pericardium is thick in CT and MRI if it's more than 4 millimeter. The reason why it's a little bit thick on imaging, that's because of the limitation of spatial resolution. So if in CT and MRI, and this is how you can see it here, how the pericardium appears very thin membrane around the heart. If you measure it more than 4 millimeter, this is thickened pericardium. In transesophageal echo, if it's 3 millimeter and above, we call it thick. And speaking about the blood supply and nerve supply of the heart, the fibrous and parietal pericardium, the blood supply is usually from the pericardiophrenik and musculophrenic branches, and the nerve supply is from the phrenic nerve. And as we know, the phrenic nerve is usually made from the fusion of C3, C4, and C5, and that's why when we have pericarditis, the chest pain is usually referred to the trapezius or the neck, and this is usually referred pain radiating from the parietal pericardium. On the other hand, the visceral pericardium blood supply is from the coronary arteries, and it's insensitive to pain, the visceral pericardium. The nerve supply is usually the autonomic fibers by the cardiac plexus. So it follows the heart. So the same nerve supply of the heart, the same blood supply, the coronary arteries of the heart. Moving to, I just wanted to say that if you'd like to ask any question, if you'd like to interrupt, if you would like to make a comment, please feel free. This is a 90-minute talk. I don't want to be very boring. And I think it will be also quite educational. If you want to ask any question, please feel free to ask. The normal pericardium usually is thin and compliant, and it fully transmits intrathoracic pressure changes. And that will be transmitted to the pericardial space, to the cardiac chambers, and the pulmonary vein. And that has effect on the heart mechanics. So with inspiration, the RV filling increases slightly because of increased venous return, and that's because with inspiration, as we all know from, again, medical school, inspiration will reduce the intrathoracic pressure that will be transmitted to the pericardium. The pericardial pressure will reduce, and that will allow more venous return during inspiration. However, the LV filling will be preserved, and vice versa will happen during expiration. And that's the physiological ventricular interdependence. And the heart usually keeps a balance by ventricular filling throughout respiration. This is the normal anatomy, physiology, and kind of cardiac mechanics in relation to the pericardium. Moving to pericardial diseases, if you have any questions, as I said, you can always ask. But moving now to pericardial pathologies and diseases, it's always good or interesting to think about them as a continuum. So this is usually a continuum of sequelae. It starts with inflammation, and it can progress to effusion, and pericardial effusion can have tamponade physiology, and some patients with ongoing inflammation, they can end up in fibrosis and constriction. Having said this, not all patients necessarily need to progress through every stage. So there are patients who just go from, for example, if you can mute, please. Yes, thank you. They can go from inflammation to constriction, and some people, they can go through all these stages. I will start with the pericarditis entity. Pericarditis is inflammatory disease of the pericardium with potential overlap with myocarditis. And that's quite interesting observation that has been made, and there was a lot of focus on it in the recent 2025 EAC guidelines. So the task force of the guidelines, they introduce a new term. So as we all have acute coronary syndrome, acute aortic syndrome, we now have acute inflammatory myopericardial syndrome. And that's because they noticed and they realized that both myocarditis and pericarditis, they have similar etiologies and are anatomically contiguous structures with possible secondary involvement. So many times we'll find patients have myopericarditis, and they also introduced the term myopericarditis when the patient have pericarditis predominantly presentation, or perimyocarditis when the patient has a myocarditis predominant presentation, or an isolated myocarditis or isolated pericarditis. But it's quite important to know that there are a lot of overlap between myocarditis and pericarditis. And speaking about epidemiology, the incidence, it's not very common. It's 3 to 32 per 100,000 person years. The clinical impact of pericarditis represent 5% of ED chest pain presentation and 0.2% of cardiovascular admissions. It affects mainly young males, and it's quite important to know that up to 30% of the patient, they can have recurrence after the first episode. And if you have one recurrence, there's up to 50% chance that you have recurrence, repeated recurrence, and that has long-term burden on patients. The first recurrence is usually around the 18 months. This is the most common window for having the first recurrence. And as I said, if you have one recurrence, you have 50% chance to have recurrent, more episode or more recurrence of disease. It can be quite, difficult to treat and with repeated episodes. The prognosis is usually low. In mortality, in hospital mortality is around 1%, mainly it rises with age in elderly and patients who have severe infection. The etiology can be generally vary with geography and clinical context. In developed countries, the most common cause is idiopathic or viral causes. It predominates. In developing countries and also especially in Sudan, TB is quite common. So tuberculosis is the leading cause, or it's very important, one of the causes to consider. Other causes, post-cardiac injury syndrome. This is an increasing cause due to cardiac surgery. It can be transient. It can cause transient pericarditis. And also it can be related to intervention in aging population. Other causes for pericarditis, systemic inflammatory diseases, autoimmune diseases, malignancy, different malignancies. And there is one important note, and also this is something that has been for the first time mentioned in the 2025 guidelines, which is about recurrent pericarditis. They found that there is a lot of genetic and there's a lot of association with autoinflammatory disorders in recurrent pericarditis, and that's with a frequency of 5 to 15%. The common autoinflammatory disorders associated with recurrent pericarditis is familial Mediterranean fever and TRAPS. And there has been found that to be an immune-mediated predisposition. So some people, they were found to have an immune-mediated predisposition for multiple recurrences. And that's why in the guideline for the first time, genetic testing is being, I think, class 2A, if you have recurrent pericarditis, or even if you have family history of family history of myopericarditis, you can request genetic testing. And it also, the genetic testing has some, there is base of genetic testing for familial Mediterranean fever as well, which support the note. The clinical stage and classification of pericarditis, it can be acute if it's 4 weeks or less. It can be subacute or incessant if it's 1 to 3, if it continues, the symptom continues to 1 to 3 months. It can be chronic if it's more than 3 months. It can be recurrent. Patient can get remission, but remission can be with or without sequelae. So what are the sequelae? If you have, for example, myopericarditis, you can have scarring in the heart. So you can have complete remission, but yet you can have some scarring in the heart. So this is remission with sequelae and remission without sequelae. But generally speaking, the stages are acute, subacute, chronic, and recurrent. The clinical forms of pericarditis, it can be dry, Zika pericarditis, which is half of the cases. It can be effusive pericarditis. When you have pericarditis with pericardial effusion, you can have effusive constrictive pericarditis when you have the patient come with chest pain, they have some pericardial effusion, and they have by echo, you can demonstrate that there is constrictive physiology from the effusion. It has a hemodynamic effect on the chamber filling and the heart filling. And you can have pericarditis with cardiac tamponade, depending on the etiology. The diagnosis of pericarditis is primarily made on clinical ground. This is very important. So usually the diagnosis, it's clinical. It's not imaging, it's not echo, it's not MRI, it's clinical diagnosis. This is usually supported by inflammatory markers like raised inflammatory markers like CRP and ESR and high leukocytes. And also it can be supported by imaging like echocardiography. CMR is not always indicated. It can be sometimes indicated in special cases of pericarditis, but as we know, cardiac MRI offers the most sensitive non-invasive confirmation of pericardial inflammation and disease activity. And I will discuss later in the following slides when MRI is indicated and when it can be helpful. But usually the diagnosis is clinical, symptom and sign, and you listen to the patient's story, and this is supported, as I said, by labs and ECG, and you have to do echo as well. These are the cornerstone for the diagnosis. And in special occasion, you can do more imaging if it's not straightforward. So this is the 2025 kind of approach to patient with acute inflammatory myopericardial syndrome. So they usually say, as you can see in the first part, that this is a quite, I'm not sure what's that blue thing, but anyway, there are so much overlap between the myocarditis, pericarditis, and that's in between is the myopericarditis or perimyocarditis, as I mentioned earlier. So they acknowledge that there's a lot of overlap between these two entities. And you have to assess the clinical classification, as I mentioned earlier, of these inflammatory myopericardial or myopericarditis syndrome. It can be acute, it can be subacute, chronic, recurrent, and if they go into remission, as I said earlier, it can be with or without residual. Common etiology can be infectious, like different viruses, bacteria, parasites, and it can be non-infectious, autoinflammatory, autoimmune, genetic condition, cancer-related, drug-related. The clinical presentation is quite diverse. It can vary from oligosymptomatic, like very mild symptoms. Patient can present with chest pain. We all know that the chest pain of pericarditis is pleuritic-like. It's quite sharp. It gets worse. It radiates with a trapezius ridge. Usually, what do you call it? Get worse when you lie flat and it gets better with sitting forward. This is the typical, right? And then some patients, they can have really serious presentation. They can have arrhythmias, ventricular arrhythmia. They can have heart failure if there's an associated myocarditis. They can have fulminant, what do you call it? Perimyocarditis or myopericarditis. And in so many patients, sudden cardiac death is the first presentation, especially in fulminant pericarditis. The initial assessment of the IMPS that has been recommended by the ESC guidelines for all patients, you have to do clinical history and symptom assessment. You have to do physical examination, vital signs, ECG, lab values, looking for inflammatory markers, and echocardiography. This is for all patients. And I will convince you through this presentation, especially about the echo, because sometimes people, maybe old school, they will say, why to do echo? I mean, if a young patient came to for example, to the emergency department or, for example, admitted in cardiology, and he has typical pericarditis chest pain that has been, for example, followed some flu-like symptom, and you have the typical ECG of pericarditis with some increasing, with high white cell count and high CRP, why I will do echo? I mean, the patient is stable, he's not dizzy, clearly is not in heart failure. But I think echo is quite important, and I will convince you later on why echo is important. But moving forward, if the patient came with chest pain, I think we always, this is our priority. We want to rule out ACS. We want to rule out acute coronary syndrome before we label him as pericarditis, right? Because this is the first thing you need to rule out when patients present to the emergency department. So if the patient has low likelihood for acute coronary syndrome by clinical presentation, chest pain doesn't sound anginal, echo biomarkers, troponin is negative, its ECG is not in keeping, and most importantly, the story, then you will label him as as pericarditis. If the patient has a moderate to high likelihood to have coronary artery disease, you do CT scan if he has moderate likelihood, and if it's high likelihood, of course, we'll do coronary angiography. So the first thing is to rule out acute coronary syndrome. This is in the ED or emergency department setting. Then you do the risk profile. If the patient has after the risk assessment is usually done after you do your baseline, which is, as I said earlier, clinical assessment, ECG, lab, and echo. Then you do a clinical risk assessment. If, for example, troponin is high and you think this is a myopericarditis, if the patient is low risk, and again, I'm going to show you how you risk stratify these patients, you need to do cardiac MRI. Cardiac MRI is mandatory if it's available, of course, and feasible in myocarditis patients. If patients are high risk, meaning they presented with hemodynamic instability, ventricular arrhythmia, fulminant presentation, heart failure, invasive endomyocardial biopsy might be needed for histopathology confirmation and guiding management and treatment. Further assessment following this, it depends on the clinical presentation, and it can be individualized, like searching for etiology, doing genetic testing, looking for drugs, doing extra testing. But the final diagnosis has to be either pericarditis, myocarditis, or myopericarditis if the presentation is pericarditis predominantly, or perimyocarditis if the presentation is predominantly myocarditis. And then the final therapy is dependent on the final diagnosis and risk and complication of the disease. So this was the recommended approach by the ESC. So these are the red flags for pericarditis. Like when patients come, when do you suspect this is pericarditis? If the patient has recent or concomitant flu-like symptom or gastroenteritis, the pain is usually pleuritic or infarct-like chest pain. If patients have right-sided heart failure, if patient has fever, pericardial rub, can you mute, please?
Yes.
Thank you. If there's pericardial rub on clinical examination, if there's pericardial effusion on echocardiography, if there's pleural effusion, because usually they present with polyserositis kind of presentation, and if MRI imaging, for example, showed any edema or enhancement. These are the things that make you suspect pericarditis. It's mainly the flu-like symptom, the chest pain, the fever, high inflammatory markers. They also kind of they provided this diagnostic criteria for myopericardial syndrome. They say pericarditis is either definite, possible, or unlikely, and that's when the patient presents with chest pain, for example, with more than one additional risk factor or additional criteria. These are the criteria they put. So if the patient came with chest pain and pericardial rub, for example, or chest pain or ECG changes suggestive of pericarditis, high CRB, pericardial effusion, and MRI finding if the patient has MRI. So if you have more than one criteria, this is definite pericarditis. Which is like, for example, pain and pericardial, pain and ECG changes, pain and high, typical chest pain of pericarditis and high CRB. And so if you have two of this is definite. If you have one, this is possible, and if only chest pain with nothing, with no additional criteria, this is unlikely. These are the risk stratification. I mean, earlier they say you have to stratify. Remember in the previous slide, we say we need to risk stratify patients, either high risk, intermediate risk, or low risk.
معلش دكتورة داليا لو قربت السماعة شوية صوت.
انا بس ما عارفه يا دكتور دسوقي، الحاجه الزرقاء دي شنو دي دي عملتها انا ولا ما عارفه اروح منها
والله
كيف؟
ما عارف صارت من
لانها
وين.
في السلايد حقتي ما موجوده.
آه
يمكن يا ربي يمكن يكون من القلم ده احتمال. لحظه
احتمال من
ادو
الكلام معايا.
آه،
Now it is clear. Thank you very much.
ما في حاجه زرقاء صحيح؟ زي
آه
في خط ازرق كده في السلايد، زي
آه
شخبطه كده.
لكن ما بأثر إن شاء الله.
ده شكلها غريب جدا، انا ما عارفه من وين جات. اوكي مسحتها.
لا.
خلاص
أوكي.
مسحنا، رجعنا.
تمام. تمام.
طيب الريستراتيفيكيشن اوف كده احسن الصوت، سامعين
Yes.
كويس؟
Yes. Yes.
طيب تمام. The risk clinical risk stratification is very important. Why? Because you need to admit high to intermediate risk patients inside because they have high risk of complication. Low risk patient can be discharged. They can be treated as an outpatient. Also, if you have high risk patient, this also can have implication on management. What are the high risk? I will also only mention the high risk criteria. So if you have signs and symptoms of cardiac tamponade, طبعا this is high risk. If you have constriction physiology, echo, this is high risk. If patient is febrile, this is a high risk criteria. And if the patient has incessant pericarditis, meaning العيان كان عنده pericarditis, but for example, he was low risk, you discharge him, you gave him ibuprofen, for example, he came in after 2 weeks and still having ongoing symptom. He did not respond. So this is what do you call it? Ongoing, either failure to treatment or bigger incessant. Incessant is usually more than 4 weeks. اللي احنا قلنا 1 month to 3 months is called incessant. So if patients who fail to respond within 2 weeks to treatment or continue to have pericarditis symptom up to 3 months, these are considered as high risk patients. High risk patients. There is also imaging criteria. If you have large pericardial effusion more than 20 millimeter in end diastole, if you have cardiac tamponade, and if you have extensive pericardial delayed enhancement on cardiac MRI. Why these criteria are considered as high risk? That's because these kind of patients are they have high risk to progress to complication. They can have constriction. They are having most likely ongoing inflammation, which can end in constriction or cardiac tamponade and hemodynamic compromise. So these are the patients. I think if I from this table, I will only remember the high risk criteria. When to admit, when you have this high risk criteria, you have to admit patient. Also, if you have intermediate risk, you might consider also admitting the patient, which is if you have signs of heart failure and if you have moderate to large pericardial effusion. بس يعني الحاجات دي كلها من الايكو. يعني اذا عملت العيان ايكو، عشان كده قلت لكم الايكو when patients come with pericarditis to the emergency department, it's quite important to do echo because it helps in risk stratifying patients and predicting complication and what can be the sequelae. لانه احيانا الchest pain والECG can be quite deceiving. I have 3 case presentation at the end and I will convince you why relying only on ECG and chest pain can be very deceiving. فزي ما قلنا the cornerstone, the story, ECG, lab, echocardiography, and in some patients, high risk patients, you might do more. You might do MRI, for example, and you have to admit high to intermediate risk patient. تمام؟ هنا I don't think I'm progressing. أيوة كده تمام. أيوة. These are the lab evidence for inflammation. We mentioned them before. We have high CRB, high ESR, neutrophilic leukocytosis, and you have to do troponin for all patients to check for myocardial involvement. ECG طبعا we know this is, we all know this. There's usually widespread ST depression with raised J point. صحيح? Which is this is in comparison or in contrast to the ACS, where usually it's a kind of an ST segment. The whole ST segment is post the J point is elevated. لكن دي دايما بيكون في pericarditis, it's a raised J point. It's a generalized ST depression in most leads. and there's usually an SCD-PR depression with it. And the reverse usually is in AVR. We usually have SD depression and PR elevation. The stages of pericarditis in ECG, usually we have different stages. The first stage is the diffuse ST segment elevation with reciprocal PR segment elevation and ST segment depression in AVR and occasionally V1. The second stage in pericarditis is normalization and going down of the ST segment and PR segment. And in stage 3, we have widespread T-wave inversion. And the final stage is normalization of the T-wave. So these are the ECG stages of pericarditis. Transthoracic echo very important. You might not see anything, can be completely normal. In 40 to 50% of cases, you can get some pericardial effusion. It can be small, it can be moderate or large. It can give you a clue to the etiology of the pericarditis. You can see, for example, mass. It can be malignant, for example. So it can sometimes give clue to the etiology. You need to assess for constriction physiology and tamponade physiology in echo to risk stratify your patient. MRI occasionally needed, not occasionally, but sometimes needed, and it's important to know when you need to do the cardiac MRI, and that's when you have still question of and you don't know what's going on. Yani you did everything, you assess the patient clinically, you did the ECG, you did the labs. The labs, for example, you have troponin of 9, CRB is not very high, ECG is normal, patient has pericarditic chest pain, echo is normal. You're not sure what's going on. Or if you have troponin, a high troponin, in that case, you are suspecting that there is myocardial involvement. And we know that echo is not very good in myocardial characterization. You want to characterize the myocardium and the pericardium, you need to do cardiac MRI. It gives you plenty and a wealth of information. So the MRI, it can assess function of the heart. It can assess the pericardial thickness. Exactly, you can measure it. Very hard to do that by transthoracic echo. As you can see in the first image here, this is the pericardium. You can easily measure how thick is the pericardium. It seems prominent. In the second square, this is called black blood sequence. And for those who are not very familiar with cardiac MRI, we have عندنا sequence اسمه black blood. We call it black blood because the blood is black. And in this black blood sequence, usually we assess edema, very sensitive to water. And hence you can image inflammation. And that's one of the strengths of cardiac MRI. So that pericardium become white, and that's edema. So this is acute inflammation. Then the last one is a different sequence. It's called the late gadolinium enhancement. It usually and what do you call it? It usually image the scar, but in pericarditis, it's very interesting that so the delayed gadolinium enhancement is usually the pericardium usually is black as this, but if it's white like this, it's usually it means that it doesn't mean scarring necessarily scarring, but it means ongoing inflammation, ongoing kind of chronic inflammation, because it reflects new vascularization, pericardial new what do you call new revascularization. And this is something that has been proved in I think post-surgically. There was a study in Cleveland Clinic in 2011 where they studied patients who have a positive gadolinium delayed enhancement, and they went into pericarditis. Sorry? So they went into they did pericardiectomy, and then they took the pericardium and they did histopathology. So they found the group of people. So there were a group of people who have delayed enhancement, and there were a group of people who did not have a delayed enhancement. They found that the patient who have delayed enhancement in gadolinium sequence, so this sequence usually it shows scarring in other pathologies, but in pericardium it's a bit different because they found those patients, they have ongoing inflammation, increased fibroblast proliferation, And hence they thought that can be a potential target for therapy. And they don't usually have calcification in their pericardium. So this is kind of ongoing chronic inflammation with fibroblast proliferation. So this is how cardiac MRI can help. This is in addition, cardiac MRI can assess constriction as echocardiography, and it can show you if there's any effusion. It can show you the effusion. It can assess also myocardial involvement. So if you have perimyocarditis, it can show scars in the myocardium, and that's also a strength of the MRI modality, which other modalities cannot show you. So you can assess the pericardium, the myocardium, physiology, anatomy, inflammation. So this is an image of inflammation. It's quite important again when we do cardiac MRI. As I said, if there's problem in diagnosis, number one. And number two, it's quite important also, it plays a major role in patient with difficult to treat pericarditis, patient with incessant pericarditis, patient with recurrent, multiple recurrences. These patients are very difficult to treat. And MRI, all the guidelines, the American and the European, they suggested to have their, to make the anti-inflammatory management guided by imaging. So for example, they will give the medication or anti-inflammatory medication till the inflammation subsided, besides symptoms, of course, till the edema subsided before they start to taper. Or for example, the duration, they will increase the duration till the edema subsided. So that, this is the also another kind of role for cardiac MRI in management. Okay. Other imaging that can be helpful, it's not class 1, but they can come. For example, if you don't have MRI, and again, you can do CT scan, and as you can see here that there is pericardial thickening and there's enhancement. You can see that the pericardium is a little bit bright, so this is enhancing by contrast, which reflects pericardial inflammation. In some rare occasions also, you can do FDG PET CT scan when you have it in your center, and it can image inflammation, but it's quite, its role is not well established yet. But it can be an alternative of inflammation imaging if you don't have a cardiac MRI. But it's very expensive and the availability is quite limited. طيب. Any questions before I go to management? طيب. Pericarditis therapy, we have to understand what's the goal of management. The goals are to relieve symptom, especially the chest pain, and improvement of chest pain is a reflection that the inflammation has subsided. And that's why when we go further, you will notice that the guidelines, they say don't taper, or you have to give high dose non-steroidal till the chest pain and markers has improved, then you start to taper. Otherwise, the patient can have recurrence. So the goal of treatment is relieve symptom, achieve remission, and prevent recurrence and complication, which is usually constriction and tamponade. The management is usually kind of multidisciplinary. It can involve different specialties. It's mainly around the clinical cardiologist, but pathologists can be involved, especially if there's endomyocardial biopsy. In case of myocardial involvement, it can involve interventional cardiologist if intervention is needed for pericardial tamponade, cardiac or thoracic surgeon if a pericardial window is needed, psychologist, because of, if you have incessant and difficult to treat and recurrent pericarditis, it has a lot of toll on the mental health of these patients, because they're usually young patients, can be very anxious. It may involve geneticist in patients with recurrent pericarditis and an identified gene for that, especially if there's family history. It can involve infectious diseases in tuberculous patients, for example, immunologist and rheumatologist. And this is very interesting kind of specialty now, the cardio rheumatology or cardioimmunology. And that's because, when I'm coming in the next slides, you will see that in patient who does not respond, for example, to non-steroidal, now they advocate adding interleukin-1, an immunotherapy we don't, as cardiologists, prescribe them, so you have to refer your patient to the rheumatologist. It can involve cardiac intensive care specialists if patients have cardiac tamponade or very annual or pulmonary myocarditis with cardiogenic shock and needing for support devices. It can involve electrophysiologists, cardiac imaging specialists. So the inflammatory myopercardial syndrome is quite a big thing, and the presentation can be quite diverse, and it can involve different specialties. The general principles, what the first advice to the patient, you have to ask patient to restrict exercise, whether they are athlete or non-athlete, until remission, and for at least 1 month. This is class 1. So you tell them, don't overexert yourself, stop exercise for around a month or so. If the resting heart rate is above 75 with persistent symptoms despite anti-inflammatory medications, you might prescribe them beta blockers, and if they don't tolerate it, you can prescribe ivabradine and that can help in reducing, because if you reduce and slow down the heart rate, it can reduce the pericardial friction and the chest pain. It's important also to do the lab test to monitor inflammation, CRB, and as we said at baseline, and use CMR only in complicated and difficult cases to confirm remission and guide treatment duration. But in uncomplicated cases, we said echo is only needed. We don't need clinical and echo to guide remission. Type. So exercise restriction, and if heart rate is quite high with persistent symptom, consider rate lowering medication. Type. Acute pericarditis. So we have different kind, and each type of pericarditis, there are treatment algorithm for it. Acute pericarditis first episode. We all know first line non-steroidal, full dose aspirin or non-steroidal anti-inflammatory. Usually we give it regularly, like every 8 hours. Colchicine is a must to reduce recurrence. Very important, maintain the attack dose until symptom resolve and CRB normalizes. Then you consider tapering. It's usually around 1 to 2 weeks. So usually the patients are expected to improve, and the inflammatory markers are expected to resolve within 1 to 2 weeks, and then you start to taper your non-steroidal anti-inflammatory drug or aspirin. Gastric protection when using NSAID, because the doses are very high, especially aspirin. Aspirin is crazy high dose, and I mean, gastric upset is expected. If the patient, if aspirin or NSAID is contraindicated, you can use low to moderate dose corticosteroid plus colchicine. But as we know, steroid, there's always the risk of recurrence once you start to taper it. But if non-steroidal is contraindicated, you can use low to moderate dose corticosteroid, especially in autoinflammatory, like patient with SLEs and all of that. If the patient has incomplete response, like for example, he came in after a couple of weeks, still having ongoing chest pain, still having high inflammatory markers, you might consider triple therapy, which is non-steroidal / aspirin plus colchicine plus low to moderate dose steroid. In recurrence, there's an advice that try to avoid giving higher dose of steroid, because the problem is when you increase the dose of steroid, there's always the risk of, once you start to taper, patient gets recurrence of symptom. طيب, incessant or recurrent pericarditis, the core regimen is colchicine. Colchicine is the cornerstone, with non-NSAID or aspirin or low dose steroid. And in many cases, we do triple therapy. زي first presentation acute pericarditis, because in the we usually start with the colchicine and NSAIDs. We can also use colchicine low dose steroid. If recurrence occurs during steroid taper, keep colchicine but add NSAID. So يعني إذا العيان بدأ يحس بإنه the pain is coming back, you make it a triple therapy if you started with two agent. طيب. If patient did not, even if you put triple therapy and patient did not improve, you start referral to rheumatology, because then the patient needs escalation of his treatment. And here the anti-interleukin-1 therapy you know, will play a role. So the anakinra and ranolosept, these are interleukin 1. They have been approved for treatment of recurrent and difficult to treat pericarditis. Those patients, despite having triple therapy, they they continue to have symptoms once you start to taper them, and it can be quite exhausting. So the anti-leukin 1, anti-interleukin 1 therapy supported for steroid-dependent colchicine-resistant cases with elevated CRB and can work as monotherapy and enables faster steroid withdrawal. الحاجة المهمة شديد اللي عايزة أنبهكم ليها بالنسبة للانترليوكين 1 therapy, they are mostly effective in inflammatory pericarditis, which is supported by high CRB. عشان كده هتلاحظوا لو قريتوا الامريكان بوزيشن ستيتمنت, they even say you have to do يعني cardiac MRI. طبعا احنا الكارديك MRI قلنا في الانسيسنت والديفيكالت usually it has role لو موجوده طبعا available. لكن حتى لو ما موجوده, اذا لقيت ال CRB وال ESR are high reflecting that there is kind of ongoing inflammation, the anti-interleukin 1 therapy are mostly effective in those patients. لأنه في other entity بيكون عندهم incessant or recurrent pericarditis, but they don't have high inflammatory markers. Those patients, they are usually يعني better treated with steroid, but لو steroid still with the NSAID and colchicine are not effective, then you can still use and try anti-interleukin 1 therapy. ولكن they are not effective, they are not as efficient لأنه هم anti-inflammatory. Having evidence of ongoing inflammation um, is, uh, is quite important for the effectiveness of the anti-interleukin 1 therapy. Colchicine is usually kept the longest, we have to put it all the time. في other options إذا العيان حتى الانترليوكين anti-interleukin 1 therapy is not effective, في azathioprine و IV immunoglobulin و hydroxychloroquine وهكذا. These things we need to know about them, but usually we don't prescribe them. It's usually prescribed, as I mentioned, by the rheumatologist. They have more experience in prescribing them. A last resort طبعا إذا كان pericarditis is very stubborn, it's an ongoing thing. You try everything, patient improve a little bit, and then again pain recurs either like shortly or after a couple of months. You can do pericardiocentesis and pericardial window لو العيان عنده pericardial effusion, وin extreme cases pericardiectomy. ناخد البريكارد ده كله برا وخلاص يعني this can be done in experience centers طبعا, high volume center. Cleveland Clinic, they have big center for treating pericarditis and pericarditis symptoms, especially difficult cases. عشان بس to summarize everything و not to confuse you, I will go through these diagrams وبعدين حنلخص الحاجات. طيب, patient with symptom and signs of pericarditis. قلنا cornerstone, first line assessment with history and physical examination, ECG, echo, X-ray, routine blood including CRB and troponin class 1. طيب, شخصنا البريكاردايتس وقلنا احنا patient is unlikely to have acute coronary syndrome. السؤال الثاني حتسأليه نفسك, does the patient has high risk features? قلنا ال high risk features, العيان عنده ongoing fever, restriction physiology, tamponade, or incessant pericarditis, ongoing pericarditis despite treatment. إذا العيان عنده any of these high risk features, إذا كان yes, this is high risk patient, you need to admit him. You have to look into etiology, and he is likely to have anti-inflammatory therapy, including interleukin 1. إذا العيان ما عنده high risk features, he can be treated as an outpatient. You need to assess response to treatment after 2 weeks. If he respond, he's low risk, continue as an outpatient. You can request echo imaging maybe in 6 months and 1 year, just making sure that everything is fine, or just seeing him in the clinic, making sure that everything is all right. If the patient did not respond after 2 weeks, you have to risk evaluate and you have to admit him to make sure that he responds to treatment. Patient with ايوه ده المانجمنت ستيبس حقتنا نفس الكلام. قلنا class 1 exercise restriction, first level therapy اللي هم الاسبرين or NSAID plus colchicine. This is class 1. This is the first step in management. طيب. Then you assess response to treatment. If he responded to treatment, after 1 to 2 weeks, you start to taper the aspirin and NSAID. Colchicine will continue for 3 to 6 months to reduce recurrence. طيب. If the patient in 2 weeks did not respond to treatment, he's likely to have incessant and he's likely to have recurrent pericarditis. This is an ongoing inflammation. So low to moderate dose of corticosteroid plus colchicine, or even قلنا triple therapy اللي هم non steroidal steroid and colchicine. فدي الخطوة الثانية. يعني الخطوة الأولى aspirin NSAID colchicine. إذا ما تحسن, you add either you put steroid plus colchicine or triple therapy, and then you assess the response to treatment. If you respond to treatment, you start to taper your steroid. Colchicine will continue for at least 6 months. If the patient did not respond to treatment, بتمشي للستيج 3 اللي هم الانتي انفلاماتوري الانتي انترليوكين 1 ايجنت الاناكينرا والرالونوسبت. خلاص. فدي الستبس. الكورنر ستون او الفيرست ليفل ثيرابي نون ستيرويد الاسبرين كولشيسين. الثانيه you try to introduce if the patient did not respond والانفلاماتوري ماركرز عاليه steroid either as a replacement or as an add-on. والاخر حاجه اذا العيان still continue to have inflammation and chest pain, interleukin 1 agent. طيب. This is, I'm not going through this, but the table is quite useful. It tells you how to taper and how to continue your treatment. You can always refer to it. Few words about immunity and inflammation in pericarditis. Pericarditis is an interleukin 1 driven autoinflammatory disease. And colchicine and anti-interleukin 1 agents اللي هم anakinra and rhinolocept, they reduce recurrences, and this is supported by animal studies, genetics, and clinical trial data that these two medications, they target the interleukin 1, and this is the main drive for pericarditis, and that's why it has been approved. زي ما قلت لكم قبل موضوع الجينيتك تيستينج دي حاجه جديده. It's class 1 now. It's recommended to obtain family history including pedigrees in cases of recurrent inflammatory myopericarditis syndrome to provide clues to underlying etiology and determine inheritance pattern, identify relative risk. الحاجه دي احنا we are more aware about it في المايوكاردايتس، يعني لانه عارفين المايوكاردايتس can be a precursor for cardiomyopathy to so many cardiomyopathy. عينين احيانا they are labeled as myocarditis بس هم بيكون عندهم genetic susceptibility، وبتلقى الام ار اي حقتهم فيها a lot of enhancement and scarring، وتسال في الفاميلي هيستوري عندهم a lot of family history of heart failure and cardiomyopathy. لكن حتى البريكاردايتس patient with incessant and recurrent pericarditis, you have to ask for family history, and you have to offer patient, it's class 2A genetic testing, especially if they have family history of inflammatory myopericarditis syndrome or inherited or suspected cardiomyopathy in patient with severe ventricular arrhythmia, in patient with significant late gadolinium enhancement and scarring of their myocardium in cardiac MRI, in patient with recurrent myocarditis or persistent troponin elevation, and recurrent pericarditis with an inflammatory phenotype, refractory to conventional treatment with the aim to detect an underlying genetic cause. So حتى recurrent, حتى in absence of family history, it's class 2A to offer them genetic testing. This table discusses the follow-up for myocarditis and pericarditis. It's usually you have to do the clinical evaluation ECG and blood test in 1 month and 3 months, and then you can do imaging in 1 year, and after 1 year, you know, if indicated in clinic, especially if patient has myocardial involvement. بس يعني عادة الfollow up at 6 months is quite important to make sure that the patient does not have chest pain and there's no elevation of inflammatory markers, and he's clinically all right with no heart failure. آخر حاجة في البريكاردايتس tuberculous pericarditis. I'm sure you'll know more than tuberculous pericarditis than I do because you're treating it more. Tuberculous pericarditis, it's usually subacute presentation. Patient presents with fever, night sweat, and weight loss, chest pain, and dyspnea, usually associated with large or recurrent pericardial effusion. They can have tamponade and very high risk to develop constriction. It's high risk groups are usually tuberculous endemic regions and HIV and immunosuppressed patients. And usually the inflammatory markers are very high. We diagnose it usually in addition to the clinical symptom and sign. Echo, it shows effusion plus or minus tamponade, and it can show constriction physiology. CT and MRI, it can show pericardial thickening and enhancement, lymphadenopathy, and concomitant pulmonary tuberculosis. الكورنر in diagnosis طبعا هو البريكارديال fluid and tissue. You evaluate it. It's usually exudative. It has lymphocytic predominance. The adenosine deaminase is usually more than 40. This is highly sensitive and specific for TB or tuberculous pericarditis. FV smear is low sensitive, but culture is usually the gold standard, but it takes very long time. There are other kind of, what do you call it, serology that can be done that can be quite helpful. It's called expert mycobacterium tuberculosis and rifampicin test for the bacteria mycobacteria DNA and rifampicin resistance. And pericardial biopsy can be indicated in extreme cases if the diagnosis is uncertain. Management is usually antituberculous, and corticosteroid can reduce constriction risk, and especially in HIV negative patients. And complication tamponade قلنا يعني which need agent pericardiocentesis, and constriction is quite common in tuberculous pericarditis. 6 months mortality is up to 40%. The risk of constriction up to 50% without treatment طبعا. And early diagnosis and prompt therapy improves outcome. احنا كده خلصنا بالبريكاردايتس. في few things بس عايزة أسأل إذا في أي حاجة يعني do you want to reflect, do you want to comment, do you want to ask before I go to the tamponade physiology?
إذا patient يا boss معلش if
تفضل.
there is a patient with tuberculous pericarditis newly discovered ولسه ما start الانتي-tuberculous treatment وكان ب shortness of breath جاء ورب فالإيكو diagnosed him as pericarditis معاها diastolic dysfunction grade 3 بعد ذاك patient develop severe pain what we can give to relieve the pain apart from prednisone.
effusion يعني هو effusive pericarditis قصدك يعني tuberculous effusive pericarditis without constriction, والفكرة كلها how to treat the pain, right? الpain usually is anti-tuberculous مع الكورتيكوستيرويد. ده اللي انا عارفاه يعني زي ما قلت لكم انا I don't usually treat, I don't have much experience in tuberculous pericarditis, لكن you can always use the non-steroidal, لكن عشان to treat the inflammation if it's infectious I think you have to control the infection. This is the ultimate thing. The corticosteroid can help reduce the inflammation والeffusion. الeffusion إذا the effusion can not causing hemodynamic if the effusion is causing hemodynamic significance يعني كان عامل hemodynamic compromise or عامل reduced cardiac filling طبعا ده you need to tap the effusion. ولكن إذا كان الفكرة كلها inflammation it's steroid and then you wait for the anti-tuberculous medications to work. لأنه this is what's causing the pericarditis and inflammation. ما عارفة if anyone can يعني أنا زي ما قلت لكم not the expert يعني لا يفتوى يعني
يا
فأنت لكن
دكتورة
ممكن
داليا لو سمحت لي
تفضل.
here we have a lot of cases of TB,
نعم.
pericarditis, and tuberculous pericardial effusion in Sudan. And here in Lubaid, we have a lot of cases. I published a paper very few months ago. We have TB pericarditis in about 5% of cases, but I think it is much higher than this. And usually it depends on the lymphocytic oxidative effusion. يعني if we have
نعم.
lymphocytic oxidative effusion, usually we start antituberculous after screening the patient to be HIV negative. After 2 weeks, we add steroids. يعني بنبدأ
Yes.
أول antituberculous. If the patient is HIV negative, after 2 weeks, we start steroids to reduce the constriction physiology, which is high, and I think يعني it may reach up to 50%.
50%, exactly.
أيوة. Some cases we add colchicine. يعني some cases they still continue to have symptoms. We add colchicine in addition to antituberculous, and usually after 6 months most of the patients they respond very well. يعني I don't think يعني we have يعني high cases that we refer them for the surgeons for pericardiectomy. Most of the patients they respond to the treatment. Thank you.
نعم. الفكرة كلها إنه الكلينيكال سسبشن وستارتنج ذا ميديكيشن تايملي I think، لأنه بعد ذاك إذا بقى الموضوع إذا كان الانفلاميشن يعني if it's too late and the pericardium is very thick it might be يعني more difficult to treat. بس يعني yeah, I totally agree with you. إن شاء الله
Yes,
نكون إحنا answered your question.
yes,
Can
exactly.
I
Thank you very much.
can I just come in, please?
معلش يا واصل دقيقة سؤال، يعني هل أنا ممكن أدينا نون ستيرويدال ولا it's not indicated in this case to relieve the pain؟ كان بيقول لي أديني حاجة البين سيفير.
عادة هو زي ما قلت لك يعني هو you can give the non-steroidal، ولكن هو عادة non-steroidal في الفيرال الايديوباثيك. يعني زي ما قلت لك إذا الانفلاميشن هو الانفلاميشن will continue لأنه العيان عنده tuberculosis و it's an infectious pericarditis يعني in the meantime you can give painkillers, you can give colchicine, you can give steroid if he's HIV negative. بس yeah this is what I can tell يعني. لكن يعني أنا ما أتوقع إنه مثلا اسمه شنو هو tuberculosis medication it takes some time to work. أتوقع بعد كده in the gradually the chest pain will improve. بس ما في contraindication يعني ما في مثلا ما أتوقع إنه في contraindication لنون steroidal or for example في contraindication مثلا to give him any other painkillers. You can try that. There is no contraindication. الحاجة الوحيدة اللي قاعدة أتفضل بها دكتور دسوقي إنك you have to be cautious before starting steroid إذا هو immunosuppressed ولا لا for different reasons سواء كان HIV ولا حاجة تانية. بس دي الحاجة. بس there is no harm of trying. I am not aware of any contraindication for example to non-steroidal or colchicine. Colchicine حتى هو يعني it has been used in tuberculous pericarditis. بس I don't think there's any contraindication. ما في ما يمنع if it can help the patient till the TB medications لأن هي ultimately you have to treat the cause till the tuberculous medications kick in.
لو سمحت لي دكتورة داليا، شايف أستاذنا دكتور عبد الرحمن زيادة وأستاذنا بروفا الباشا دكتورة صفاء، أستاذتنا دكتورة صفاء أحمد حسن. طيب نديهم فرصة نشوف رأيهم والإكسبيرينس حقتهم إن شاء الله.
أنا الغريبة ما شايفة
Can I
الناس لكن أيوة
اتفضلوا أساتذتنا.
come in, Disugi?
اتفضلوا أستاذنا دكتور عبد الرحمن زيادة.
All right. Dr. Dalia, thank you very much for bringing up this interest forward كده. The 2025 statement or guidelines have reshaped the way people think about things. The problem about guidelines regarding us who are with limited facilities is that it keeps giving you new classifications. It moves away the mix-up that you have put together as a bundle for all patients, but equally make a lot of demands regarding the diagnostic process. And I think this is what will face people in Sudan. And in fact, the clinical thinking has to go that way and the facilities be improved. There are two things. There is one interesting thing in the 2025 is the emphasis on the use of colchicine. Now, نحن في السودان, some of the treatments or medications, we had a lot of quality reservation as to whether to use or not. And this is due to classical teaching in the past, is that colchicine is a bad drug, colchicine is dangerous, colchicine is a lot of side effects. And that's why you find so many people reluctant to do that. It's the same happened with steroids and respiratory disease, etc., etc. And patients have been deprived because of the side effects and the complications, etc., etc. Now, with the so many classifications or phenotypes that you have described so far, it makes it a duty that we have to specifically diagnose before we go on commenting ourselves to treatments. I have to say that the ILS 1 and 2, the interleukins or the anti-interleukins, were not known to us. It has to be put forward. But the problem about it, again, if you want to start these effective treatments in the so many patients that come with recurrent pericarditis in Sudan, of course, you have to have facilities to confirm that it's an inflammation and go on with it. And that puts more demand on things. So I invite صلاح الباشا لأنه كل سنتر في السودان يكون فيه CT and MRI. Thank you very much.
Thank you very much. Thank you.
Thank you very much, أستاذنا دكتور عبد الرحمن زيادة, for this valuable talk. And really, we appreciate the presence of our great teacher, دكتور عبد الرحمن زيادة, with us. يعني دايما ملهمنا, ويعني ربنا إن شاء الله يحفظه ويديه الصحة والعافية. أستاذنا الباشا.
بارك الله.
السلام عليكم أصدقائي الأجلاء، البروفيسورات والأستاذ. معلش أنا بتكلم نيابة عن أستاذنا بروفيسور الباشا. احنا شغالين معاه الآن، شغال في لايف سيفنج PTMC، فبيعتذر عن الحضور.
تمام الله يديك العافية.
Can I reflect على الكلام دكتور بروفيسور عبد الرحمن زيادة؟
Yes.
few comments. أيوة. أيوة صراحة كلامك فعلا، يعني مرات لما تشوف الجايد لاينز بتقول إنه يعني we are far away from the guidelines. والواحد في النهاية it has to be realistic. You have to reflect on your local resources, how we can utilize these guidelines to treat the patients. أنا تخيلية يعني من الجايدلاينز دي الحاجة ممكن الواحد يطلع بها المهمة، إحنا دائما we kind of think about the pericarditis as something simple، إنه ما حاجة، يعني خلاص العيانين ديل. وأنا حاسة عندي في at the end of the presentation يعني I hope إنه الناس أو الحضور يكونوا موجودين to the end عشان أقنعهم إنه يعني الواحد لما يعني we should not underestimate pericarditis، لأنه أحيانا بتكون في time bomb يعني behind them. It's not that simple. حتى لو هو كان only a disease of the pericardium، يعني ما في other like acute aortic syndrome behind it ولا مصيبة تانية، هو في حد ذاته it can be very difficult و it can البيشنت he can end. فأنا الفكرة بتاعت الريسك stratification I think it's quite important. It's a new concept. We have to, when patients come, we have to risk stratify them. دي حاجة مهمة and we need to follow them up. يعني دي ما يعني كونينك تشوف يعني تدي العيان مثلا موعد بعد 3 شهور، بعد 6 شهور، تتأكد إنه والله الانفلاماتوري ماركس حقته نزلت، العيان is getting response, he's not getting more chest pain. إحنا we can treat patient clinically and with the simple resources without doing cardiac MRI. يعني الانفلامation ممكن أحيانا ال C-reactive protein it can وال ESR وال high white cell count it can reflect inflammation. A chest pain CT scan is cheap, it can be available. I know it can be difficult بس ممكن تعمل CT scan برضه it can show you إذا كان في inflammation. echo عشان تتأكد ما في constriction ما في tamponade. فأنا I think إنه embedding the concept إنه pericarditis can sometimes يعني it might not be that simple. وإن إحنا we have to be aware إنه it can be quite complicated, it can has a lot of consequences وعنده a lot of burden on the patient. دي حاجة مهمة من ال guidelines. الحاجة الثانية المهمة برضو يعني زي ما تفضلت أنت يعني الأوفرلاب، فكرة إنه إحنا نعرف إنه في حاجة اسمها مايو بيريكاردايتس بعد كده تروبونين، نعمل الإيكو نتأكد إنه القلب function is good. يعني ممكن a different presentation ذاته إنه it can be a pericardial effusion, it can progress to tamponade. دي برضو حاجة مهمة. الحاجة الثالثة أنا ما بعرف إنه الروماتولوجيست والانترليوكين وين هل هي available ولا ما available ولا يعني how what's the availability, what's the price. definitely هتكون حاجة غالية جدا. لكن interestingly مثلا الجايد لاينز اللي كانت تتكلم عن في one of the alternative management كان بيذكر hydroxychloroquine اللي هي برضه تستعمل في الاس ام اي والحاجات دي. هي خدتنا as one of the things الاي في immunoglobulin. فانا اتوقع برضه يعني involvement of other specialties and sharing يعني ده بس في ال difficult patients. يعني if you have a difficult patient يعني we find it difficult to it's not حاجة دي ما حاجة احنا بنلقاها every day. يعني sometimes you encounter those some patients that can be difficult to treat. I think it's important also to have a shared kind of management أو يعني to consult other specialties وتشوف مثلا إذا في مثلا يعني reflecting on the guidelines لو في other anti-inflammatory medications that can help the patient. And we can build on our own experience. زي ما قال دكتور دسوقي يعني مثلا قال شايف إنه مثلا consciousness is always helpful. It helps the patient usually they don't have chest pain, they with the steroid they don't have. So this is the local experience. Maybe hydroxychloroquine in difficult patient, it's a cheap medication. It might help those patients with incessant and recurrent pericarditis, and we can build our own experience. شكرا جزيلا.
Okay, thank you very much, Dr. Dalia. And I think we can step forward, Dr. Dalia,
Yes.
to complete.
ناخد منكم زمن آي. البريكارديال effusion is the second entity في البريكارديال pathology spectrum. We are all familiar with transthoracic echo, and transthoracic echo usually it can give us the size of the pericardial effusion. Can size it as small, less than 10 to 20, more than 20, as big.
معلش دكتورة داليا السماعة شوية.
Sorry.
Thank you.
So that the size of the pericardial effusion and location can give etiology. If it's, for example, in this case here, this is an exudative white pericardial effusion. You can, affect also hemodynamic significance of the pericardial effusion. It's kind of an algorithm on how to deal with pericardial effusion. I will just go fast through it. You do echocardiography, and then imaging can be helpful. CT can help to tell you if this is, يعني أحيانا الإيكو it can tell you if this is, it can give clues that if the effusion is exudative, if there's fibrinous material and it's quite echogenic and quite thick. It can also, sometimes if you have hematoma, post-surgical and bleeding, it can give you clue, but CT is more sensitive. With Hounsfield unit, we can tell if this is exudative or exudative or purulent or even chylous because it has negative. So CT can tell you about that. MRI it can help in diagnosis of pericarditis and inflammation as in effused pericarditis. The management is usually if you have hemodynamically significant pericardial effusion, you do need the pericardiocentesis. We all know straightforward, and if not, you have to check if there is pericardial inflammation by inflammatory markers or advanced imaging if they are available, CT and MRI. And if yes, you give anti-inflammatory depending on the cause. And if no, you just follow. And if it's large, you can do. We know that there's a score that you have to go the ESK score. If it's more than 6, you can consider stopping. If there's constriction physiology, you can also treat the constriction with anti-inflammatory. I mean, we will discuss constriction in the next lecture anyway. Cardiac tamponade, this is the last thing I'm going to speak about, is a life-threatening hemodynamic syndrome in which increase in pericardial pressure equals or exceeds intracardiac diastolic chambers, resulting in impaired ventricular filling and hemodynamic compromise. So this is the hallmark of the hemodynamic of the cardiac tamponade, is that the intrapericardial pressure, when it reaches the level which exceeds the pericardial reserve, and then it's equal to or exceed the intracardiac diastolic pressure, then this will affect the hemodynamic and the ventricular filling and the hemodynamic compromise, and patients started to get hemodynamically affected. The most common causes of cardiac tamponade include malignancy. It can be iatrogenic injury or trauma, pericarditis in some cases, tuberculosis, autoimmune diseases, uremia infection, aortic dissection, and less frequently. Again, going through the hemodynamic. I like hemodynamic, and I like always to link the hemodynamic with the clinical examination and imaging. It helps you to explain everything. So tamponade occurs when intraepicardial pressure, as we mentioned, exceeds cardiac chamber pressure, impairing filling, especially during diastole. Very important that cardiac tamponade is not a fluid problem. It's a pressure problem. And we all know that if even small amount of fluid has accumulated in a short time and the pericardium pressure reserve has been exceeded, that can result in tamponade, as in, perforation. We all know this in cath lab. And sometimes if it's chronic, usually the stretch and the reserve is big in the pericardium, and the pericardium can contain up to 500 mL of fluid without having any tamponade physiology. So it's a pressure problem. It's not a fluid problem. The pericardium can accommodate slowly accumulating fluids, but once, as I said, the reserve volume is exceeded, the pressure volume curve steepens dramatically. So small increases in fluid can cause large increases in interpericardial pressure. Diastolic chamber pressures are exceeded, and chamber collapse occur, and cardiac output falls. This is the pericardial pressure volume relationship. It's a J-shape curve, and in the flat curve here, usually the pericardium with accumulating pericardial volume, as long as the pericardial reserve is not exceeded, the pressure inside the pericardium does not go along, and that's the flat curve. And with the increasing pericardial volume accumulation, and when the pericardial stretch is reached, the pressure will increase dramatically, and then cardiac tamponade physiology occur. This can occur quite acute and steep if the pericardial and the rate of accumulation is quite rapid, as an iatrogenic pericardial effusion. But if the pericardial effusion is slowly accumulating, this can be quite delayed, and the limit can be like the pericardium can accommodate a big volume before it reaches its limit, and the pressure rises and tamponade happens. And this is quite important graph, and it tells you the different phases of the pericardial tamponade. So at baseline, this is the first phase of pericardial tamponade. The intrapericardial pressure is quite low. It remains well below the right heart filling pressure and the left heart filling pressure, and this allows the chambers to this allows the chamber to dilate during diastole, to fill in, and that also maintains the transmural pressure of the heart. And then with accumulating fluid, the interpericardial pressure gradually increases till it reaches, in the second stage, it equals with the right heart filling pressure. And usually, because the right heart chambers are usually low pressure chambers, so it usually equalizes with the right heart filling pressure or diastolic pressure first, and then in the third stage, it equalizes with all the heart chambers, the left and right heart filling pressure and intrapericardial pressure, they all equate. And then once this is reached, the intrapericardial pressure kind of increases exponentially. And for the heart to fill in, the venous pressure has to increase a lot in order to fill the heart, because the intrapericardial pressure is quite high, and it equalizes. So to fill in the heart, the venous pressure has to go very high, and that reflects on the high JVP. And despite this, the stroke volume drops a lot, and all of the ventricular filling and chamber accommodation of the cardiac filling, it depends on the septal shift and exaggerated ventricular interdependence. So once tamponade physiology develops, venous pressure rise to maintain inflow, but effective chamber filling falls and stroke volume declines. And established tamponade, the pericardial pressure approximate in all cardiac chambers, and this is in the third stage, producing functional diastolic pressure, equalization and marked reduction in cardiac output. This is the final stage of established cardiac tamponade. And the predictable progression of tamponade or hemodynamic cascade, it follows a predictable sequence of events. So it's first of all, there is the rising pericardial pressure. As we said, it's usually it equalizes first with the right heart chamber, then the left heart filling pressure, and then all diastolic pressure equalizes, and then this will impair the right first. It impairs the right-sided diastolic filling. Right atrial collapse happen because this is the lowest chamber pressure, the lowest chamber with low pressure. So with the right atrial collapse happens usually early. The right ventricular diastolic collapse, and the result of, and then we will have exaggerated ventricular interdependence. So earlier, as we remember that we said during inspiration, the intrathoracic pressure will be transmitted through the pericardium, and the pericardial pressure will reduce, allowing the chamber to increase inside the right ventricle. However, in pericardial tamponade, because the pressure inside the pericardium is too high and it's compressing on the right ventricle, the only way for the right ventricle to accommodate the venous return is for the septum to bow to the left side during inspiration, compressing on the left ventricle and impeding the left ventricular filling. And hence, with inspiration, the LV filling will reduce. And that's why we see pulsus paradoxus, right? So in pulsus paradoxus, in cardiac tamponade, when you put your hands in the patient's pulse, when the patient takes a deep inspiration, the pulse is become quite faint, right? And then when during expiration, it becomes stronger. And that reflects the interventricular septal shift during inspiration and expiration, because for the right ventricle to fill in and accommodate the venous return, the interventricular septum has to shift to the left side during inspiration, and the reverse happens during expiration. So the left ventricle slightly increase, and to increase its filling, the septal shift to the right side. So the septal shift from left and right to allow each chamber to kind of fill with each during inspiration and expiration, and that can be clearly seen by echocardiography, and this is what we call it exaggerated interventricular dependence, and this is clinically how we assess, and this is how explain the pulsus paradoxus, which is quite specific and sensitive sign of cardiac tamponade. I think the sensitivity is 98%, and the pulsus paradoxus, if it's above 12 millimeter of mercury, it's up to 80%. There are other causes for that, but cardiac tamponade is one of the most important things. Then we have the respiratory variation in the mitral and tricuspid inflow, and that's also reflected the filling of the ventricle, right? So with the change in the filling in each chamber with respiration, that will reflect into the mitral and tricuspid inflow and the septal shift to each side. IVC is usually dilated and plethoric and non-collapsible, more than 2.1 centimeter and with less than 50% collapse. But we always have, in medicine, there's no white and black, right? There's always exceptions for that. And ultimately there's reduced cardiac output, hypotension, tachycardia, and pulsus paradoxus. Is the hemodynamic cascade is clear؟ لو في أي واحد عنده يعني سؤال الفيلوز وكده يعني لو I can explain it further, but because I think this is the basis of cardiac tamponade, understanding the hemodynamics, which explains the clinical signs and symptoms and the imaging findings as well. Tips and pitfall. We can have regional tamponade. Regional tamponade may not have the same echocardiographic signs as the typical tamponade. You might not have IVC dilatation. You might not have right atrial and right ventricular collapse. You might have collapse on the left side if you have a big hematoma sitting next to the left ventricle or left atrium, for example. Patients who are hypovolemic, also they might have right ventricular and right atrial collapse in absence of tamponade. So if you're doing echo for a patient and you see right atrial collapse or right ventricular collapse, it's not always tamponade. It might be just hypovolemia. IVC also, it has to be interpreted in the context of clinical context and how, if the patient is hypovolemic or not. طيب, symptom and sign are caused by reduced cardiac output and reduced cardiac output and venous congestion. As we know, because of the pericardial constraint and impairment of cardiac filling caused by increased interpericardial pressure. There's reduced cardiac output, and the venous pressure increases in attempt to improve the cardiac filling. All the signs and symptoms are reflective of this. Patient present with acute breathlessness, most common presentation because of reduced cardiac output, chest discomfort like pressure, fatigue, dizziness, syncope, and reduced exercise tolerance. Clinical examination, they might have tachycardia and weak peripheral pulses. Pulsus paradoxus is defined by more than 10 millimeter of mercury inspiratory fall in systolic blood pressure. ما عارفة إذا ممكن حد يورينا how do you measure pulsus paradoxus. I mean ده يعني do we all know how to measure it by sphygmomanometer? Should I go through it ولا حاجة معروفة؟ عموما هو البلسس بارادوكسس حتى كلينيك اللي ممكن يتشاف، يعني ممكن الواحد يحسه زي ما قلت لكم بالبلس examination. الواحد البيشنت when he's sitting and he's breathing you can appreciate إنه البلس volume بيقل، it become faint during inspiration and it becomes stronger during expiration. By sphygmomanometer,
Can I
if
ask
this is
you,
more than 10 millimeter.
can I ask you to go through it, please? If there are a number of fellows attending.
هل في حد يتبرع يقول علينا؟ خلينا نبقى مور انتراكتيف يا دكتور دسوقي. انا تكلمت ليلة ساعة ونص بتكلم.
اوكي يلا يا شباب.
بتخت الكف وبعدين تبدأ ترفع هو you inflate your cuff. بعدين you start to listen. في الأول بتسمع الكورد كوف sounds دي intermittently. فأول ما تبدأ تسمع في الكورد كوف sounds دي صح؟ you mark this number and then you continue on deflating. أول ما بتبدأ تسمعها during inspiration and expiration you record the number and the difference between them is the pulses. يعني this is the pulsus paradox. If it's more than 10 millimeter of mercury this is pulsus paradoxus because physiologically it should be less than. Actually physiologically هو ما بيحصل. هي الفكرة كلها إنه the first time you only see you only hear the sound during expiration. أول بدأت تسمع during inspiration and expiration. الفرق بين الحاجة دي first course cough sounds and then when you start to listen to them in inspiration and expiration this is the pulsus paradoxus. مفهوم ولا عقدت عليكم؟
لا شكرا. هي طبعا انا I'm asking you to do that because all of us think that they know it. The reality of the matter, it is not practiced often. And that's why it has to be reminded because it's a valuable
صحيح.
sign.
Yes, true. طيب. Tilpex triad has been described for cardiac tamponade, which is raised JVP, hypotension, and muffled heart sound. So if you have this triad, this is suggestive of cardiac tamponade. أنا حمشي سريع شوية لأنه الزمن ذاته جا. JVP دي حاجة مهمة في examination. So this is the normal JVP. In cardiac tamponade, it's the typical JVP is prominent X descent and blunted Y descent. لماذا؟ لأنه ال Y descent لأنه ventricular filling is impaired and it's uniformly impaired throughout diastole. This is in contrast to constriction. لما نجي للconstriction بتلقى إنه عندنا prominent X and especially Y descent. Why is that؟ لأنه constriction is a different hemodynamic. Constriction is a fibrous shell. The heart starts to dilate and then as if there's an elephant behind the door, it just knocks on the pericardium. So you have an abrupt, sudden, interruption of diastole. So there is early diastolic filling, but it's short and interrupted. في البericardial tamponade, the cardiac tamponade, it's blunted throughout diastole, but we have prominent X descent. I might just skip this. these are the exceptions where you can have tamponade without pulsus paradoxus. إذا العيان كان عنده hypovolemia, if he has moderate to severe aortic regurgitation or aortic dissection. The ECG, we have low voltage ECG with electrical alternance اللي هي every other beat بيكون في changing of the voltage from one beat to another beat. في تاني chest X-ray, you see cardiomegaly in 89%, especially if the effusion is more than 300 ml. Echocardiography في ثلاث حاجات. You have to see it in tamponade to assess for three things. طبعا you see how big is the effusion. We say the big effusion if it's more than 20 millimeter, but it's not, tamponade is not a volume problem, it's a pressure problem. You have to remember this. It's not the size, it's the hemodynamic. Anyway, you assess the size of the pericardium, the location of the pericardium. Is it loculated? Is it circumferential? You see the chamber collapse. So in tamponade, we have early diastolic right ventricular collapse because this is the time where the right ventricle pressure is the lowest in early diastole, and you time it with the ECG. So this is one thing. We have also right atrial collapse in apical forward chamber view. I will show it later. Here also collapse. We have the inspiratory variation. الأوروبيين مختلفين على الأمريكان. الأمريكان بيقول لك 30% 60-30% for the mitral and tricuspid. اليوروبيان في latest guideline بيقولوا 40-25%. So 40 more than 40% change في الترايكاسبيد inflow و more than 25% change من الانسبيريشن to expiration في الميترال inflow. زي ما قلنا change يعني لاحظتوا إنه هنا في الانفلو في اختلاف يعني بيزيد وبينقص على حسب. So في الليفت ventricle احنا we said during expiration the mitral the LV filling increase. وفي ال right في الترايكاسبيد inflow during inspiration هنا بيكون أعلى شيء. ف this is the زي ما قلنا because of the septal shift and filling of each chamber, it reflects on the mitral inflow, which reflects the ventricular filling. It also manifested clinically as pulsus paradoxus. IVC typically is dilated and non-collapsible, ولكن أحيانا زي ما قلنا في الhypovolemia and special conditions, it might not be the case. You have to be open-minded. So these are the three things: chamber collapse, ventricular interdependence, إذا بيقول شنو إذا الفيوجن big بيكون في swinging of the heart, respiratory variation in the mitral and tricuspid inflow, and IVC dilatation and being non-collapsible. So the very interesting, that was a case report we reported many years ago. This is an echo showing respiratory septal shift with inspiratory RV dominance and reduced RV filling. شوف هنا شوف أول ما هي شغالة ما حتشتغل ما عارفة. So anyway, this is the subcostal. You can see the RV, the right ventricular early diastolic collapse. الحاجة الثانية المهمة اللي تلاحظوا ليها exaggerated ventricular interdependence. كيف تشوفوها؟ إنه تلقى إنه الهارت الليفت ventricle شوف الرايت ventricle هنا صغر كبر 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 صغر. This is phasic with respiration. So during inspiration بيكبر بعدين بيصغر بيكبر بيوسع, and that's because of the septum shift to the left side. During expiration it becomes smaller because the septal shift to the right side. أنا ما عارفة ده ليه ما اشتغل, لكن خلينا نجرب مرة ثانية. هي نفس شوف هنا برضو شوفوا left ventricle is getting bigger and smaller, and that's because of the septum. Septum move to the left and to the right. هنا left هنا to the right, and that's during this is phasic with respiration, and that's to allow the ventricle to fill. وزي ما قلنا الانسبيريشن it moves to the left side, right ventricle يكبر, left ventricle يصغر, tricuspid inflow velocity تزيد, mitral inflow velocity تقل. During expiration septum move to the right side, the mitral tricuspid inflow هيقل, mitral inflow يزيد, left ventricular size هيكبر. Okay, this is called exaggerated ventricular interdependence. This is the collapse, right ventricular collapse clearly هنا شايفينها, وهنا right atrial collapse كما تكون الصورة واضحة. This is a modified apical four chamber. Okay. Uh, this is M mode. It shows برضه نفس الحكاية إنه this is the mitral valve. During inspiration, mitral valve become very small because the flow across the mitral valve become very small during inspiration. نفس الحكاية هنا you can assess the هنا this is failure of aortic valve opening because during inspiration as well, because the stroke volume become very low to the point that during inspiration the aortic valve fails to open. This case was reported, I remember, many years ago in a patient. It just reported that we reported the hemodynamics of cardiac tamponade in patients, what do you call it, having their aortic valve fails to open with changes in mitral valve and aortic valve. It's just interesting hemodynamic. LVOT as well, inspiration and expiration. During inspiration, in the LVOT, the flow begin, which reflects the برضو the filling of the left ventricle. During expiration, BZ. The same thing. قلنا الكارديك tamponade. This is the score, the EAC score. طبعا إذا العيان hemodynamically stable هو very clear, you go for pericardiocentesis. But sometimes if you have very big pericardial effusion, you need to calculate. This is the EAC score, if the patient is likely to tamponade or not, and you calculate the score. It's a different score from clinical presentation, etiology, and imaging by echo. And then if it's 6 and more, you consider tapping of the effusion. Management is usually emergencies. زي ما قلنا, you avoid diuretic. Sometimes you are tempted to give diuretic with the effusion and dilate the IVC, but the cardiac output is quite low. You are pushing the patient and tipping him to tamponade if you give him diuretic. Volume expansion sometimes can be needed for low pressure tamponade. Diagnosis is usually clinical. It's not echo. Echo confirmatory. It's clinical usually. Echo confirms and guide treatment and timing. اخر حاجه انا عشان كده مشيت اخذت زمن اكثر منكم، بس في 3 cases and I think it will be very interesting. انا ما عارفه هل عندكم وقت لا ولا خلال المره الجايه، انا بس ما عايزه اخذ من زمانكم اكثر من كده. انا خلصت تقريبا الثيوريتيكال في 3 cases. انا قلت when pericarditis is not what it seems. انا am open, I can come, I have another session, I can add it to the constriction. وإذا you're interested I can show it with you.
والله يا دكتورة دالي، يعني الكلام معاك طبعا ممتع، ونحن لو علينا تتكلم اليوم كله، لكن طبعا نحن
there is time
عاوزين
limit.
عاوزين
Yeah.
الحاجات دي لأنها مهمة. نبدأ بها الناس يكون يعني زي ما بيقولوا شاربين الشاي
fresh.
حقهم وفريش،
أيوة.
وانت ذاتك فريش. و if you
نعم.
don't mind اللكشة الجاية لو بديتي برضو بالكاردياك تامبونات كده، برضو اديتيه حاجة كده مسحة كده، وبعدك مشيتي على الكونستريكشن يكون أحسن، لأنه
حاضر.
يبدو لي يعني جاهم في النهاية كده ما أظن يكونوا مركزين معك كويس يعني.
خلاص إن شاء الله.
thank you very much يعني دكتورة داليا for this elegant talk. والحقيقة
الله
يعني
يبارك فيك.
استمتعنا جدا يعني بالمحاضرة، ونحن عاوزينك تعيدينا إنه اللكشر يعني نكمل البريكارديال ديسيزز، وبرضه عاوزين لكشرز في الكاردياك سيتي إن شاء الله نبرمجها معاك لاحقا بإذن الله.
إن شاء الله إن شاء الله.
تمام
عندنا أيوة.
تمام.
في minute ممكن.
داليا. Thank you
اتفضل.
داليا very much.
اديك العافية
يعني very
غدا.
valuable very valuable lecture. أول مرة أنا يعني أجلس في محاضرة كده من البداية للنهاية و very attractive. فيعني ما شاء الله very great lecture with يعني very valuable information.
الله يديك العافية.
فرصة
تسلمي.
سعيدة إنه لقينا أساتذتنا
نعم.
ودكتور زيادة، يعني فرصة سعيدة وسعيدين شديد بإننا لقيناك اليوم، وشكرا
يا
لك
اهلا
دكتور الدسوقي.
يا مرحبا بك، اهلا
فرصة
وسهلا.
جميلة. دكتور زياد والله أنا سعيدة إني لقيتك اليوم، وسعيدين شديد بمشاركتك.
والله انا سعيد جدا باللمه دي، بما انه
الله
انا
يديك
هسه
العافية
دلوقتي
والصحة يا رب.
انا زي الجد اللي قاعد احفاده قاعدين حوالين.
والله سعيدين
لا
شديد، يعني
والله
أنا سعيدة إني
بالعكس.
لقيتك يعني من سنوات، ويعني فرصة سعيدة شديدة. الصحة والعافية يا رب.
الله يبارك
شكرا
الله
لك يا
يبارك فيك،
داليا،
كتر
يعني very
خيرك. الله
valuable
الله
lecture.
يبارك فيكم. لو في أي كومنت، لو في أي حاجة. أنا خليه فعلا زي ما قال دكتور دسوقي، يعني خلينا الحاجة الدسمة يمكن للنهاية. لكن أنا قلت أركز على الأبديتس حقت البريكاردايتس، لكن أنا عارفة دايما الهيموداينامكس والحاجات دي، بس عشان كده قلت الكونستريكشن أخليه in a different presentation. لكن لو في أي من الفيلوز ومن الحضور، لو في أي زول عايز كومنت أو يعلق أو يصلح، لو غلطت في حاجة، لو في حاجة قلتها ما صح، لو في أي تعليق please feel free to يعني comment.
بس أنا I want to add يعني زي ما قلتي إنه البريكارديال يعني disease it is underestimated يعني always, and sometimes it يعني patient يعني appear stable but it will went rapidly into permanent acute pericarditis. I have one patient before it, maybe يعني maybe few months back. The patient presented with severe chest pain and he's young, and the echo severe يعني the echo revealed no, the echo revealed severe LV systolic dysfunction with mild pericardial effusion. The patient appeared stable, and only the negative sign that he has tachycardia. The heart rate was more than 120, and he has mild heart failure. And then investigation revealed cardiac troponin. It was very high. It is like MI range, and the lactate was high. And this يعني very يعني important signs يعني to indicate this
high
patient is
risk.
high risk.
أيوة,
Yeah.
this is speaking about
The
risk
lactate,
stratifying.
yeah,
أيوة.
and troponin. And then the patient went into severe fulminant, and despite MCAs and everything, the patient unfortunately and he died. Yeah, sometimes it will be underestimated, the pericardial disease. And I think very important sign is tachycardia is very important signs, lactate and serum troponin. It will reveal and reflect the extent of the myocardial damage.
نعم.
لكن يعني it was very great lecture.
Thank you so much ندى، يعطيك العافية.
دكتور محمد بنقة، تفضل.
السلام عليكم، كيف الأخبار؟ شكرا دكتورة داليا على المحاضرة الجميلة دي.
الله يبارك فيك.
وصراحة والله رتبت لنا حاجات كثيرة، وأنا عايز بس تشير حاجة جاتني يمكن في الأسبوع اللي فات ده. وكويس إنه يعني عندنا مشكلة، يعني العيانين اللي بيكونوا هاي ريسك بروبرتي للكورونا ارتري ديسيز. فكان عندي عيان ده الإي سي جي بتاعه كان هو 75 years old non diabetic، وكان عنده flu like symptoms قبل كم اسبوع كده، وبعدها كده بقى صارت عنده زي one of fever. بعد شويه بعد لما جاء هو تحول من ميديسين لكارديولوجي، انه جاب لي تشيست تيبيكال انجينا بين، تمام، ولو اكسرسايز انتوليرانس. الاي سي جي ده اللي نزلته لك قبل شويه. بعد شويه تروبونين والكارديك ماركر والسي ار بي والحاجات دي كلها كانت التروبونين فيري هاي سنسيتيف، كان تقريبا 23، والسي ار بي كان عامل 49، والاي اس ار فيرست ريدنج كان 15 والبعد 32، والسي كي ام بي عامل 220. فكان انه البلاننج ديسيس الاي سي جي طبعا لو شايف الاي سي جي واضح ولا جاكم؟
You're not sharing. في حاجة. أيوة. now في حاجة. أيوة. yes.
في زي اول بيشنت طبعا جاتك كارديك ومبين وكده، فبقى ديسايدد هل تو جو تو كاث لاب ولا ستارتد ميديكال تريتمنت بالهاي تروبونين ده. فبعد شويه قلنا خلاص لا، احسن تو بي سيف، ومشينا على
أنجيو.
الكورونا انجيوجرام. وصراحه ما في حاجه يعني significant، كان كلها ماي اثيروسكلوروسيس ديسيس وكده. الايكو كان ديفيكالت شويه، كان عملنا زي بيت سايد كده، كان البيشنت فيري تيكيكارديك، الهارت ريت 130. بعد الجي كده العيان مشكلتهم ما بيرجعوا، فبقينا احنا توريتش الدايجنوزس بعد ما خلصنا ما في اي كورونا ارت ديسيس، ترايت الديسكريبشن للعيان يطلع بشنو. فخديناهم في هاي دوز بتاع نان ستيرويد انتي انفلاماتوري وكولوشيسين. مشكلتهم ما بيرجعوا للعيانين دي. فهل احنا اصلا كنا ماشيين في الباسوي صح ولا لا، ولا المفروض كان نعمل حاجه ثانيه؟ هو طبعا الاكسري والحاجات دي كلها ما كانت في حاجه significant.
والله هي الباثوي صح، لانه حسب كلامهم التشيست بين يعني كان بي ديسيفينج، يعني احيانا العيانين حتى لو كان مثلا، يعني انا عندي عيان كنت اخذته في الثري كيسز، وكان يعني ممكن بس اني مشي بس اخذت زمن كثير في السلايد. كان المفروض اقدمها يعني حاسه just to wrap things. نفس الحكايه، بيجيك عيان بتقول انه والله this is pericarditis like chest pain، وبكون مثلا هو late presentation MI with pericardial inflammation. فعشان كده هم بيقولوا انه يعني اذا انت كان اذا كان انت شاكي في انه في coronary artery disease it's quite important to look into the coronaries whether by CT ولا coronary angiography. المشكلة إنه ذاته أحيانا بالذات إذا كان العيان يونج، أحيانا حتى البيتنت كرونري does not rule out coronary artery disease. يعني أنت ممكن يكون عندك spasm. أنا كان عندي عيان عنده he's a cocaine abuser يعني، جانا ببيريكارديتك chest pain، ولما عملنا الكارديك ام ار اي كانت اسكيميك باتن انجري ما في، وعنده ال في كلوت كمان، وجانا بتشيست بين تحلف عليه وتقول والله ده this is pericarditis يعني، فهمتني؟ ما كان اصلا انجينال. ففي الحالات زي دي احيانا الام ار اي بتنفع. ام ار اي ما موجوده، الايكو يعني اذا الواحد حتى لو عمل ما بعرف اذا في كونتراست ايكو، المهم اي حاجه ذات كان تلو اذا كان في وول موشن ابنورمال. انا هو ممكن احس الديفرنشال بتاع العيان بتاعك دايما هو مايوكاردايتس يعني مايو بيريكاردايتس، اكشلي هو بيري مايوكاردايتس لانه هو التروبونين حقه كان عالي، او يكون مش ده، ممكن يكون هو اسكيميك كاين يعني مثلا حاجه امبوليك with some pericardial inflammation. انا عشان اعرف انا عايزه اشوف الميوكارديوم كويس، اما good bedside echo تتاكد انه ما في wall motion abnormality، ما في يعني حاجات كده انك تقول لك انه والله this is it could be مثلا an embolic phenomena مثلا يعني. او الحاجه الثانيه اذا كان طبعا في كارديك ام ار اي، بس الكارديك ام ار اي ما بتكون موجوده. الايكو ممكن تاخد تعمل كونتراست ايكو اذا كان هو بور ايكو ويندو ولا حاجه زي دي، لكن it seems انه العيان هو كان يعني الحاجه اللي قلتها دي it seems انها بيقولوا شنو هو it's a perimyocarditis kind of presentation. definitely محتاج انه يتشاف مره ثانيه وتتعاد له الانفلاماتري ماركرز وتتعاد له الايكو، مهم شديد، لانه لا ممكن يكون في ongoing inflammation. احيانا العيانين ده they end up with dilated cardiomyopathy، بيكون في ongoing myocarditis وما تحسن وما تعالج، وفي النهايه they end with LV systolic dysfunction وما يكون اصلا زول جايب خبر ذاته يعني. ف follow up is good يعني.
شكرا.
الله يبارك فيك.
Thank you very much دكتورة داليا for this very elegant talk يعني as usual. الحقيقة يا دكتورة داليا يعني استمتعنا جدا بمحاضرتك، والشباب هنا مبسوطين جدا يعني تجيني الفيدباك في الخاص يعني
انا والله بس بعتذر يا دكتور دسوقي شديد انه انا ما كنت ملتزمه بالزمن، اخذت راحتي شديد في
لا
الاول،
لا لا لا
فانا I
لا
should be within the time limit، فانا
لا لا
بعتذر
لا
للناس يعني
لا
اني طولت عليكم.
لا العفو والله ما طولتي، يعني احنا بس زي ما بقولوا ظروف الناس هنا وكده،
ايوه انا
لكن كتر خيرك كثير ونحن بنشكرك وربنا يعظم اجرك ان شاء الله.
الله
وندي
يبارك
الفرصة
فيك.
الأخيرة لأستاذنا دكتور عبد الرحمن زيادة to conclude this meeting please. دكتور عبد الرحمن welcome.
Okay. Well, أول حاجة I'm so pleased that we have so many people around the world with who reached the prime of their training, and they are in clinical practice and they have mastered the tools of diagnosis, and that they are willing to come through and help. So we have to thank Dalia for this very impressive talk, which was made in simple words, clear. I am sure everyone has had a lot of benefit, and it highlighted that there is a different trend towards the disease or the syndrome called pericarditis, of whatever it is, and it invites us, those who are able to make the decision, which I'm sure they are around here, انهم يوسعوا وعاء الdiagnostics, because it's very obvious that seeing is believing, while you don't most of the time do not believe things that you don't see. And sometimes there are indirect ways of biomarkers, there are indirect ways of tests, etc., etc. And it is very obvious that the modalities that Dr. Dalia has gone through have an impact on the treatment of pericarditis in many different ways, which are related to the specific diagnosis. Thank you, Dalia.
الله يبارك فيك.
أنا will do my best to be here all the time to listen, to get educated, to get updated, and equally, if I have a thought, which I will think that it's a strategic thought, I will put it forward.
Thank you so much.
I want Dalia to make sure that she is here all the time on demand, and when not on demand, to be here for comments and for discussion with the others. لأنه if you look at the New England Journal of Medicine last week, there was emphasis on the heart team.
نعم.
The heart team is a concept which came, I think, in 2014, recommended by the European Society of Cardiology, and that no case can be sorted out unless there is an input. And as part of that came what you have in England, the MDT, a multidisciplinary team.
نعم.
The multidisciplinary team in cardiology now has to have someone with good expertise in imaging. And you are all invited. يوم من الأيام السودان ده هيستقر. We are all invited to put it up.
نعم. إن شاء
شمروا.
الله. إن شاء
You
الله.
have
يعطيك
to get
العافية.
this improved.
يعني.
There is a lot that to be done, and you have the mind of it, you have the knowledge of it, and you have the training of it. And I think we should concentrate on these people who are accredited, certified, etc., in making the task forces. يعني أنا ما بفتكر إن المسألة مسألة opinions ولا كده. This is a matter of knowledge, so the task force has to be made of those who mastered the issue and the subject and has the experience on it. Thank you very much again, Adalia, and thank you,
الله يبارك فيك.
Yadisugi, for the effort you made. And thank you for giving me the last opportunity. I am honored by that.
ثانك يو فيري ماتش أستاذنا العظيم الجليل، ربنا يمتعك بالصحة والعافية، والمفترض ما نتكلم بعد كله ووضعناكم الله.
جزاكم الله خير. شكرا لكم كثير على
مع
الاستضافة
السلامة.
والكلمات الطيبة. الله يبارك فيك. أشوفكم تاني إن شاء الله
الله
على
يسلمك.
خير. السلام عليكم.